Hello.
Hello, everyone. Thank you for including me in this wonderful conference. I'm trying to find how to share my screen. Share screen. Okay. My goal today is to review with you the best of IBD that was presented at DDW. So I'm going to focus mainly on comparative studies that can help us position therapies in IBD. We'll talk about medical therapies for Crohn's complications such as stricture and abscess. And if we have time, if you can speak as fast as Ryan, we can touch base upon on other abstracts that were presented. The LOVE UC study looked at the efficacy and safety of using vedolizumab early in ulcerative colitis versus late in UC. So we know that anti-TNF are typically more effective when we use them early after diagnosis of IBD, mainly in Crohn's disease, but we don't know if this is true also for vedolizumab. So in this study, the investigator looked at the use of vedolizumab early in UC, and early was defined as having UC for less than 4 years and having used either mesalamine or steroid, and versus using vedolizumab late in UC. And late UC was defined as having UC for more than 4 years and a history of immunomodulator and anti-TNF use. And the primary endpoint was looking at the proportion of patient in remission at week 26 and 52. And this was defined as a total Mayo score less than 2 with no subscore of more than 1. So what we see here is that whether we use vedolizumab early or late in the course of disease, endoscopic remission at week 26 and 52 were very similar. And the combined clinical and endoscopic remission at week 26 and 52 was also similar, or all around 40%. One of the downside of the study is that many patients withdrew from the study initially, 24 patients in each group. But this analysis that I'm showing you is an intention to treat analysis that include all the patients. Also, if we look at the Mayo endoscopic subscore, and the bar on here on the left is for patients who were early in the course of UC, and this is for next is a patient who were late in the course of UC, and then therapy was started for vedolizumab. You'll see that the endoscopic score, whether you were early or late in using vedolizumab, was similar between both groups at week 26 and week 52. So what are the implications in our clinical practice? We can say from the study that vedolizumab seems to be as effective if used early versus late in moderate to severe UC. However, this could be a reflection of UC behavior itself, where if we use therapy early or late, it doesn't affect UC disease course, as opposed to Crohn's disease, where early therapy with biologic is more effective than late therapy. Next, we have a study by Ryan Ogero looking at Adeliumab and vedolizumab and how they affect healthcare resource utilization, steroid use, and disease complication when they are used as a first-line biologic in Crohn's disease. So we do have limited real-world data on cost effectiveness of Adeliumab versus vedolizumab as a first biologic use in Crohn's disease. So this study aimed at looking at this specific endpoints, and what they used as endpoint is healthcare resource use, Crohn's disease complications such as developing fistula, abscesses, perianal disease, stricture, needing to be in the hospital because of Crohn's or needing surgery, and the time to systemic corticosteroid discontinuation. So what we see here is that there's a significantly higher, there's a significantly lower proportion of patients treated with Adeliumab compared to vedolizumab that end up needing an inpatient admission or an ER visit. There's also a lower proportion of patients treated with Adeliumab that require Crohn's related surgery compared to patients treated with vedolizumab. And there's a higher proportion of patients treated with Adeliumab that achieve corticosteroid-free remission, that were able to discontinue corticosteroid during the course of their disease. So in our clinical practice, what we can, the conclusion we can have from the study is that Adeliumab is associated with less healthcare resource utilization and corticosteroid use compared to vedolizumab when it's used in bio-naive Crohn's disease. So this is an indirect comparison between two drugs, but it's very important because it can help us in positioning biologics in bio-naive Crohn's patients. Next, we have a study comparing Tofasitinib versus Istikinumab in UC patient who were previously exposed to anti-TNF and vedolizumab. The AGA recommends using Istikinumab or Tofasitinib in moderate to severe UC who had lost response or failed anti-TNF. But we don't know what is best, Istikinumab or Tofasitinib, in patients with UC who have failed both anti-TNF and vedolizumab. So this is a retrospective cohort of a large IBD center looking at this issue. And the primary outcome was steroid-free clinical remission at week 12 to 16 after drug initiation. And there was the total number of patients was small, 81 patients, 45 in the TOFA group and 36 in the Istikinumab group. But what we see here is that patients, both group, whether they're on TOFA or Istikinumab, achieve a similar steroid-free remission and steroid-free response at week 12 and 16. Around 40% of patients achieve steroid-free remission and response. And if we look at colectomy-free drug survival, it's again very similar between the two groups. So it seems that both Istikinumab and Tofasitinib are good options in patients with refractory UC that have failed or lost response to anti-TNF and vedolizumab. However, we have a small number of patients in the study, and we do need larger study and head-to-head comparison to really determine comparative effectiveness between drug and this refractory population. The CView study was the first head-to-head study in Crohn's disease, comparing Istikinumab versus Adeliumab to induce and maintain remission in patients with moderate to severe Crohn's disease. We are well aware of Varsity, which was the first head-to-head study in UC comparing Adeliumab and vedolizumab, but we don't have head-to-head trials. So this is the first head-to-head trial in Crohn's disease. The primary endpoint was clinical remission at week 52, defined as a CDI score less than 150. So what we see here is that at week 52, clinical remission was similar between the two groups, the Crohn's patient on Istikinumab and Crohn's patient on Adeliumab. And actually, we see similarity throughout the course of the therapy, and we see that both are effective at rapidly inducing remission in patients with Crohn's disease. Corticosteroid-free clinical remission was also similar between the two groups, and endoscopic remission at week 52 was also similar. So we can conclude that both Istikinumab and Adeliumab are effective therapies for Crohn's disease. However, one of the things that is, in randomized controlled trial that is a little bit different than real world practice is that it didn't take into account dose escalation and combination therapy with immunomodulator, which we often do in clinical practice. Next, I'm going to talk about studies that look at medical therapy of complication of Crohn's disease that we typically treat with surgery. So the first one is a Strident study looking at use of Adeliumab in Crohn's disease strictures. We know that up to 1/3 of Crohn's disease patients develop stricture in the course of the disease, and stricture are often managed by endoscopic dilation or surgery. And this study looked at assessing the efficacy of different Adeliumab regimen in symptomatic Crohn's disease stricture that had an inflammatory component. So strictures were assessed by imaging, MRI, or colonoscopy. Inflammation was assessed by fecal calprotectin or CRP, and symptoms were assessed by the obstructive symptom score. A baseline balloon dilation was done if it was a short stricture and it was indicated. And patients were randomized to either an intensive treatment with Adeliumab, where the induction was done with 160 milligram weekly for 4 weeks. And then maintenance was done with 40 milligram every 2 weeks in addition to thiopurine. And in this intensive treatment group, if there was continuing inflammation at 4 or 8 months, therapy was escalated to Adeliumab weekly. And this was compared to standard Adeliumab use with a standard induction and maintenance and monotherapy. And the primary endpoint was the proportion of patients with improved obstructive symptom score at 12 months. And what we see here is that there was no significant difference really in clinical and biochemical outcomes between the intensive versus standard therapy arm. They both achieve improved obstructive symptom score at 12 months at around 60 to 70%. And they both achieve steroid-free improvement in a similar way. And the requirement for surgery was similar in both groups. The only difference that was statistically significant was that on MRI, the stricture looked better in the intensive treatment group versus in the standard Adeliumab group. On endoscopy, Both treatment group achieved improvement on endoscopy, and the stricture was passable with the scope in around 40% of patients. So what we can conclude here is that standard Adeliumab therapy can be considered in a selected group of patients with Crohn's disease stricture. These strictures should have an inflammatory component and no surgical risk factors. So if there's a fistula, an abscess, or pre-stenotic bowel dilation, these patients are better served with, by surgery. How about treating abscess, intra-abdominal abscess in patients with Crohn's disease? This is a follow-up on the MICA study. The initial MICA study looked at using Adeliumab in patients with Crohn's disease associated abscesses after resolution of abscess and sepsis. In the initial MICA study, it was an induction study, and 71% of patients achieved Adeliumab success at week 24. That success was defined as no use of steroid after week 12, no intestinal resection, no abscess recurrence, and no clinical relapse. The study that was presented at DDW is a follow-up of the MICA study looking at the long-term efficacy of Adeliumab use after resolution of an abscess and Adeliumab success at week 48. This was defined as no Adeliumab failure at week 24, no intestinal resection, no abscess recurrence, and no Adeliumab withdrawal. And what we see here is that at week 48, 66% of patients achieve Adeliumab success, which means that after initiating Adeliumab after resolution of an abscess, the patient did not need resection. There was no recurrence of abscess, no Adeliumab withdrawal. And up to 85% of patients did not require intestinal resection. After 4 years of follow-up, the cumulative incidence rate of Adeliumab failure was 54%, and the resection-free survival was 75%. So we can conclude in our practice that Adeliumab can be effective in a selective population of Crohn's disease patients after resolution of intra-abdominal abscess. The thing to keep in mind is that in the study, patient had early Crohn's disease, so we're still in the inflammatory phase of the disease. The abscess were small. The medium size was 25 millimeter abscess, so these are not abscesses that require percutaneous drainage. So in this patient population with early Crohn's, intra-abdominal abscesses that are small, that resolve with antibiotic use, did not need percutaneous drainage, Adeliumab can be an effective therapy to prevent abscess recurrence, treat Crohn's disease, and prevent intestinal resection. Next, I want to touch base on 2 more studies that were interesting, looking at the Adeliumab trough level and whether low or high trough level was associated with a higher risk of infectious complication in patients with IBD. So we know that a higher Adeliumab level, more than 7.5, is associated with therapeutic response. We also know that anti-TNF therapies are associated with an increased risk of infection, and there's often a concern that higher anti-TNF drug level are associated with a higher risk of infection. So the objective of the study was to look at the infectious complication with different drug level of Adeliumab. This was a retrospective cohort study looking at more than 400 patients on Adeliumab who underwent therapeutic drug monitoring. And any infection that occurred within 3 months before or after TDM was recorded. And what we see here is that it's actually active disease that seemed to be more associated with infectious complication. Around 60% of patients with active disease develop infection versus 40% of patients with inactive disease. And surprisingly, we see that it's patients with a lower trough level of Adeliumab, less than 11, had a higher risk of infection, 65%, compared to patients with a higher Adeliumab trough level, more than 11, only 34%. And there's a similar effect of the drug trough level on the risk of infection after we account for disease activity and vaccination status. So the conclusion here is that higher Adeliumab drug level are not associated with a higher risk of infection. They are actually associated with a lower risk of infection compared to a lower Adeliumab drug level. And this could be due to the fact that a higher drug level, a therapeutic drug level, is associated with endoscopic healing, and that inactive disease decreases the risk of infection. This again also is a good reminder that it's important to vaccinate our patients with IBD who are on anti-TNF and biologic to prevent most common infection, which are upper respiratory infection and pneumonias. This is the last study I want to present. This is the association of processed food intake with risk of developing IBD. We know that we have very limited study on the role of diet in IBD. And the goal of the study was to assess the relationship between processed food intake and the risk of developing IBD. This is a prospective core study, the PURE study. More than 110,000 patients were looked at from different countries, different geographic region, and they were followed up for up to 3 years. And what the study found is that higher processed food intake was associated with a higher risk of developing IBD. And this risk was increased with a number of serving per day of processed food. And that risk was seen in each category of ultra-processed food, whether it's soft drinks, sweets, salty snack, processed meat. On the other hand, intake of white meat, red meat, dairy, fruits, vegetable, and legumes was not associated with an increased risk of developing IBD. So this is in line with other studies that also demonstrated a high risk of IBD with ultra-processed food. And this risk seemed to be higher in Crohn's patient versus UC patient. It is unclear at this point if excluding processed food from a diet has a positive impact on patients with already established IBD. I want to thank you for your time and congratulations on a wonderful conference.